Hey, my coding family, how's everybody doing today? Happy Tuesday. Yesterday we had a big old fire out here near Topak. Had traffic round and about. Had an awful time getting home. Tomorrow, let's see, Travis has a football game and James has an open house at his high school. I'm not sure how I'm going to be at two places at one time. May have to get Grandma involved, but I've got no live tomorrow either. I know I've got one up on YouTube. I'm sitting here trying to reschedule it too. It'll probably have to be Saturday because Travis has a football game on Friday too. So we'll do Tuesday, Thursday, and Saturday lives this week. Good to see you, Go-Kart. Hey, JP. Hey, Katie. Hey, Rihanna. Katie, Christine, Marissa, Janelle. Good to see you. She's got B. Good job. What about this one? We got Christine. Oh, hey here. Katie. Good to see you guys. Be sure and ask if you guys got any questions. I'm trying to find my notes. I've got how to turn your 2024 ICD-10 book into a 2025 book already posted. I'm working on the turn the 2024 CPT book into a 2025 right now. We have a whole lot of not a lot, but we do have a big set of new codes in E&M. It's the telemedicine. They've redone it, so I've been trying to figure out how to find space for all this. Let me think. I know Kim's got her exam coming up November 9th. Darla, November 5th. Renee, October 23rd. We've got Georgia, 10/27. Nikki, 10/28. Tanisha, 12/5. Renee, 10/23. Cassandra, 10/26. AD is going to be 11/18. Kate, the 26th. Yaz, 12/5. Barbara, the 23rd or the 26th. Can't remember. But now that the 2025 books are here and I'm going crazy, you know, trying to create a bunch of new 2025 documents for you guys, having time to do tutoring is going to be limited. So if you guys have not scheduled a tutoring already, there may not be a lot of space available between now and the end of the year. Just so you guys know, we're wrapping up the end of football season 2, which is crazy. Oh, where's the camera? Will that work? No, let me get that to go off. Just not enough hours in the day. Yes, I want to delete that. Let's go add a video. Yeah. Oh, how have I got it? I got it set it this way. Okay. So we've got a new set of, I'm just now starting on them. The new audio, video, E&M service codes. I don't have them all done yet, but there's codes for new patients, codes for established patients, codes for video and audio together, and then video only or audio only. So there's a whole new set of codes, and they put those codes in the 2025 book directly after your 99215 area. So immediately after the 99215 area in your CPT book for 2025 is where those telemedicine codes are going. So the only place I really have to put them, since there's going to be a really long list, is probably the end page of these guidelines, which is right before the 99212, or you know, those codes. So it's just not enough space really right after the 215, because in the 2024 book they immediately start with inpatient hospitalization, but in the 2025 book they have all these brand new codes for E&M services. So that's the only real issue. The rest of all the chapters only have like a few extra little codes here and there. It doesn't look like it's going to be anything majorly big at all. Everybody's saying C on this one? Yes. Sorry. You're trying your second attempt, but we'll keep you posted. Awesome, Katie. I'm scheduled for November 9th, Christine. I was working on a document to the study guide. I'm trying to get that sucker out. I really wanted to get that published and put out. I sent Twinkle a bunch of audits to do on it. Because I've got it done, I'm just formatting, but I have a bunch of practice exam questions that I created for it. So just in case any of those practice exam questions are incorrect or whatever, you know, I can't see my own errors. You know, when you do your own work, it's hard to tell if you've got an error in your own work when you write something. So I sent her a bunch from the very beginning of the study guide for 2025 to go over and look at, and I told her that if it's too much for her to do, to send some of it to Go-Kart and have her help you. So just in case you get any emails from Twinkle. What am I trying to do? This is not giving me an option that I want. Oh, here it is. There we go. So, like, this is part of it, the study guide, where I've gotten to. It's just doing like pages that you need to know where these are at inside your HitPix book. Go find these pages, that kind of stuff. Super helpful. And then copies of, like, this is an example of how I organize that medicine or information. And then we'll have, you know, the glossary of terms and then practice exam questions and stuff like that. So, got it almost done. Where is... this page? I wanted to change it to not that one, but there we go. But it's not right. I don't like it. Don't want that either. I want it to be already edited for you guys, so I don't have to sit here and re-edit the sizes so that it fits. It should automatically just open. There we go. Here's questions for today. Are you an E code in the beginning, or are you an N code? Would the kidneys go first, or would diabetes go first for this particular patient? Let's see. This one's probably going to have 2 pages. Yeah. And let me check up on chat. Somebody was asking questions about some codes. Saving with Shannon. She's doing November 12th. Kenesha, December 6th. Awesome. What's the difference between... Yeah, I'm still working those out. Those new codes Marissa is asking about. I can show you guys. Hold on. So it's in the HitPix book, but the new, Marissa was asking a question about the new CPT codes for 2025 for E&M. And what's the difference between the new telemedicine codes versus what we already have in the books. So this, of course, looks all the same. There's nothing new here until you get right here, these new telemedicine service codes. I'm not very good at like reading and understanding exactly what they're talking about, so I'm squeezing this in a little bit, but I was thinking about doing a video about each one of these paragraphs, and after, you know, I read a sentence, then I got to tell you what it means in layman's terms after I figure it out, right? From what I'm seeing, and this looks crazy, this little chart, and it's not very helpful at all anyway. It's just synchronous audio and video evaluation and management services. It's not called telemedicine like it used to be. Now they've come up with some highfalutin words that mean the visit was audio and video with a system that does both simultaneously. I don't know why they have to change it. We all know what telemedicine means. and the code range is 98000. But I don't know how helpful all this will be with everybody that's having their certification exam, you know, this month and next month. All this is just useless information that you guys don't need. And these codes may not even be on the exam until May of 2025. So I don't know if y'all really want to know all the differences and want to go over this right now, or if y'all want to just go back to practice exam questions. But from what I've been reading, and it just seems like they've got highfalutin. Why they got to change it from telemedicine to synchronous, I don't know. But it's just a division between new patients. These set of codes are audio and video together. So it's the same thing. We're going to have a straightforward code. We'll have a low code. We'll have a moderate code, and we'll have a high code, all under new patients. And they both have audio and video together, right? No big deal. Then we'll have established patients that have audio and video together. We'll have a straightforward. We'll have a low, moderate, all that stuff, high. They do have some weird stuff about time, which they're changing some of the wording to seem super weird about time. If you're doing an audio video call, maybe just even an audio one, you know, by itself. But if you're going to do it based off time, it's one set of codes. But if you're doing it based off of MDM, you still have to meet a time requirement of a certain threshold. So like every audio call before you bill it, whether you're going by MDM or time, has to be at least 10 minutes long. It can't be 9 minutes. It has to be 10 minutes. Even if you're not going off of time limits. So that's one thing. MDM can't be the only factor involving these. It has to be MDM plus you spent 10 minutes with the patient on the audio call, right? And then if you're not going to do it based off MDM and you're going to do it a level visit off of time, then they'll have 15 minutes, 30 minutes, 45 minutes, and 60 minutes. So, you know. And then if it's just audio only, or, and then they've got this new code that's all solo by itself. It's called a brief communication technology-based service. A virtual check-in. Don't know. Haven't looked at this. I don't know what they're talking about yet. What do they mean by that? Haven't figured it out yet. Haven't gotten there. I've only written down just the audio video ones, the new patient, and the established patients. I got that. I understand that. And for some reason, these do not have the time requirement for MDM. Only the audio evaluations only have the time requirement, even if you're doing MDM. Why? I don't know. Will all this stuff stick? They'll probably be changing a lot of this because it's just too confusing for physicians to even think about understanding. But anyway, and then they got this low bird, the 16 down here. I don't know what they're talking about here, but I'll figure it out and I'll get it simplified for you guys. The rest of E&M is the same, no big deal. Consultations, new hospital consultations, then they've got the ER visits, critical care services, everything else is the same. So it's just new telemedicine, and we can go through here. Yeah, home and rest, prolonged services, everything else is fine. Nothing else has changed. They have a couple of little sentences new on case management services, probably just clarification because people were getting confused about certain things. They added a new do not to in one of them. No big deal. They added a sentence in preventative medicine about reminding people to go to the medicine section if you're looking for the vaccines. No big deal. Easy peasy. And then, of course, they deleted some codes. Probably those telemedicine codes and stuff like that. So, yeah. And then we move on to anesthesia and anesthesia guidelines. They added just some rewording on the services and stuff, but nothing big, nothing new, not even any new codes that I remember seeing in anesthesia. So nothing's changed there at all. No big deal. When we do get to surgery, did we have any new codes in integumentary? I think there was something new in integumentary, but I might be wrong. It might be muscles. Yeah, no, not at all. So there's really not going to be a whole lot in the rest of the book. There's a lot of new Category 3 codes, but they don't even use those on the certification exam. So you don't have to worry about those additions. Those are those T codes in the back of the book. There's going to be some new ones back there. But I won't even add those in to my notes when I change a book from one code one year to another. We won't worry about those codes. But not a lot. Not a lot. They did delete a whole bunch of COVID vaccines that are no longer going to be utilized. You see all those codes for COVID. They deleted all of those. So not that big of a deal. COVID vaccine is not a question on the certification exam. So not bad. Not bad. It's just learning something new. But hopefully that helps out a little bit, Marissa. I'm still learning, and I'm working on adding those into my 2024 CPT book so that I can help explain those to you guys, but I don't believe that they are going to be an issue. If you're taking CCS as of April 31st or 30th, that's the day that those new codes will be added to their certification exam. And same thing for AAPC. I don't think there'll be an issue until April or May, but I will definitely get you guys familiar with the new codes come around January. And I'll be able to explain them a whole lot simpler by then too. Thanks, Go Cart. Yes, if I have a tutoring open on November 7th, then great, grab it. If it's open on my website, then absolutely. They probably won't change the exam. They'll change it a little bit around January 30th as far as AAPC goes. If they're going to add any fill-in-the-blank exam questions, I think that's when that will happen. And I'm assuming, it's my assumption, that it'll only affect a couple of questions at the end of the exam. You know, where those 10 cases are at the very end of the exam. I don't think all of them will be fill in the blank, but maybe a couple of them. But I don't know. I don't work for AAPC, so I can only guess. Not a lot of new codes as far as what we're going to be dealing with CPC. But there is a big section in the E&M section, but I think we can get that added into the 2024 books. if anybody wants to save their money and not have to buy a new book. Hey, McNair, no worries. Hey, Patrice. I know you were asking for tutoring too, so get it scheduled online whenever you get ready. All right, we got some different answers on this question. Some people are saying C and some people are saying A. It's a difference with that last little bitty difference right there at the end. When they are getting dialysis, right? With CKD number 5, we have a tiny little guideline with that one, and they end up getting the 6, right? Most of the time you get to match the stage 5 with the last digit on the ICD-10 code. The only caveat to that is when they're having dialysis. So if they have dialysis and they're in stage 5, that puts them to that number 6. So D is our answer with that one, just simply because of that. Most of the time, your answer would have been the other one, but this one is a trickier question. It's one of the ones that I used in my duck classes for my advanced people, you know, that were not passing the exam, and they wanted to see what kind of questions you would see that are tricky, that are the ones that you get wrong if you don't know a particular guideline, and this is one of them. You will be a 6 if you're stage 5 with dialysis. All right, are we going to query? Are we a 2, 4, or a 9 with this patient? If all you have is the GFR results, I have these written out in my CPT book. Did I write them in the medicine or the lab and pass section? Yep, I wrote it in the lab and pass section. So, add video. What if you get an extremely difficult question and they don't tell you what stage renal disease they are, and all you can go by is their lab results, right? If you have written out the stages of CKD like I have in my notes, stage 1 is a GFR less than 90. Stage 2 is a GFR of 60 to 89. Stage 3 is a GFR from 30 to 59. Stage 4 is a 15 to 29. And stage 5 is a 0 to 14. So I just have it written here on the Lab and Path main page, right here where the guidelines are at. That way I've got it just in case I ever need it. Mostly COC people might see a question like this, but just in case you got an exam from Hades, you know, and you were just given a lab result, which if you ever work urology, you might be asked to do your coding based off anything documented like this in your patient's chart. So it's a good learning activity too. What do you guys think is the answer? Don't worry about being late. I was not even ready. How many do we got on? We got 34 on, 13 likes on today's live. Thank you so much, guys. Got lots of C's. C is our answer. Perfect. What about this one? Are you a C3, a C7, or a Z status code for this particular patient? We can talk more over the new codes for 2025, but I'm just worried it's not an efficient way of use of time for those that are fixing to take their exam here in November and December. So, but totally up to you guys. I'm happy to discuss the new changes further too. Yay, here comes some free memberships into the YouTube channel. Miranda, Kat, Eva, Sophia, Maya. Yay! I hope those YouTube memberships help you guys out. Jenna says D. This one's weird. It's like, does that mean they still have cancer of the lung right now? What is that? Is that so vague? You know, I think if they have current metastatic cancer of the lung, you know it's going to be C, right? You wouldn't ever code a history first if you have a current diagnosis of cancer. So if it doesn't make it clear that they're being treated for cancer right now, but out of the available answers, I know this is not metastatic because it's a low C number. I know the higher the C numbers, that's metastatic. And if they do, and we do have to code, you can see that the C78, there is 2 codes in every answer. So no matter what, we're going to have to do 2 codes. One's always going to be a C code, according to these answers, and one's going to be a Z code. Normal patterns of what is correct will always be cancer goes first and then your status code goes last, unless it's the Z code for currently being seen right now today for radiation or chemotherapy treatment, and then that's our Z51 goes first. But if we're just talking about history of cancer that a patient has, that'll be the second code, and their metastatic will be first. So C, yes. This kind of situation will definitely be on your certification exams. A surgeon repairs 2 hernias in the abdomen that are not connected. They are 15 centimeters apart and require separate incisions. How should it be billed? We have new hernia codes and new hernia guidelines, I think as of 2023. So are we going to bill each hernia separately? Are we going to measure the hernias of the outermost portions and code that way? Or are we going to measure each hernia and add them together? Or none of the above? You're welcome, guys. Ask away if you guys got any questions. I think I had a similar question like this on my last tutoring session, but I may be wrong. About the hernias or the cancer one? I know you've had some of the cancer ones. Yeah. But this hernia question should be brand new for you. It's around the 495 area. I got here. Yep, right here. So I know this is really hard for you guys to see, but right here around the 495 area, there's this pace right here. And it says that we would measure from the superior most aspect of the upper of the defect to the inferior most aspect of the lowest defect, is what it says. I'll copy that and put that over here with this question so that you guys have it. With the answer, so that you guys see that we just, there we go. That's where that guideline is at. Which, that means it's not C is the correct answer, it's B. I don't know why C is there. I probably put down the wrong thing. But B is the correct answer. You can see from the, even the rationale here, that we're gonna just measure. So if your hernia, I'll draw a picture. If this is your stick person, right? And they have a hiatal hernia up here near the esophagus. And then they also have an abdominal hernia. 2 of them. And you're going to repair both of them today. You're going to measure from the very top of that hiatal hernia all the way to the lowest part of that abdominal hernia. And you're going to build that one measurement. That length. And that guideline again is right there near those codes at your 49591 through 9618. We don't take away, like if they're 6 centimeters apart away from each other, we don't take away all that space. We just count it all. And they give you an example. Right there, how it is. Super cool. All right. What are the two basic types of chiropractic visits that Medicare recognizes? Are they active and maintenance, active and therapeutic, therapeutic and preservation, or function and continuous? I think there used to be some questions on the exam about acupuncture. You're scheduled for your second attempt on 11/14. Awesome. This one's just active and maintenance. I know you guys have seen this one with the 11 and the 7. Just want to make sure you guys know where to find these codes, that you know there's a chart, right, in that area. And if you're doing 5 on each arm, that makes 10, right? You know how to utilize it and find your answer. We had this one, I think, even in our workshop recently. I know I've done it in tutoring, and I've done it multiple times in our live lessons. Popular question. Think about your patterns here, that add-on codes are the only ones that you times, so you wouldn't see an answer where the first code is timed and the second code isn't. So you know that C is a coding irregularity by looking at it. That'll help you get down to 75% chance. Everybody got 11 for this one, because that's how many nerves we did. What is a reasonable number of nerve conduction studies a physician may perform for carpal tunnel of the right hand? Can you utilize that chart? And do you know how many? Get one of those racing games systems in the house one of these days. I was watching James. He got quiet. I was wondering what he was doing. You guys know what the answer is for this one? Oh, hey, all right. So, in the back, near those codes, 959, in your CPT book, right? Big chart. Whoops, camera's not gonna work. It's big, huge. It's a full page long chart. It says long-term EEG monitoring table. I have to get up and go unplug my camera and then plug it back in, because it just died on me again. But it's a full page chart. You can't miss it if you're near those codes at all. This one is 7. You're supposed to be utilizing Appendix J at the back of the book also. Appendix J has another chart. C, D, E, F, G, H, I. Right before your Appendix L, it says carpal tunnel. How many limbs are studied, and then how many nerves are done, and the number 7 is written right there next to carpal tunnel. Don't forget about Appendix K is super helpful for your certification exam. So is Appendix F. F is in Frank. Is really helpful for your certification exam too. Be sure you guys know about those appendixes and how they can get you guys the answer a whole lot faster. This is a case that's going to be 6 pages long. The first thing you're going to do is think about, am I in integumentary or am I in musculoskeletal? I have 2 codes that are in the 2.2 range, or I have 1 code that's in the 2.06 range. A lot of these, probably all of these, will have different headers. Instead of going to the CPT code descriptor individually, run to the code, yes, but look at its red header and blue headers right before these codes. See if that's what you did today. What did we do? Oof, I need to make this font bigger. There's no way I can read this stuff. We got 6 pages. Formatting all these questions takes most of my day. Prepping them beforehand is crazy amount of time. Iliac screws. 2, 3, 4. 5 and 6. We got rods and screws. Contralateral side, right posterior side. What's our differences between our codes? (22015). Did we do an incision today under the header of spine? If you look back, your blue header is incision, your red header body part is spine. That's our 22015. Our 228 is under what? 22852 is under the header of spinal instrumentation. Explore Which one do you guys think we did? I would have stuck with the 222s just because they're more similar, but see a couple of A's in there. We can go look. 206, 15 is under aspiration, general, aspiration of assist. I saw lots of bones, rods, screws, things like that. We irrigated, debrided. We did do a abscess. We removed some hardware. Scalpel was used to incise the wound superiorly. Following the rod was then cut using bolt cutters and a drill. Screws were removed easily. Showed signs of infection. The hole in the pelvis was irrigated and lavaged. The neurotic wound edges were debrided. A drain was placed into the wound. And they just sutured them back up. What do you guys think is the answer for this one? Out of those, which one was the first code? I know we've done a lot of stuff to this patient, but which one would be the first thing that we would code? Of course, you can rewatch all the lives. If you're on the YouTube channel, if you're here on my social media, of course, on my site, if you go to social media, that's the YouTube channel. So if you go there, you just use this headers right up here at the very, very top to switch over to videos, shorts, lives. Click on the lives and they're all listed here as in date of order so that you can watch all the 2-hour free live lessons I've done every week for the past 4 years. You can see them all in their terrible glory. There's a million of them, but they all have the date on them so that you can go back and watch as many as you want, for sure. And that's all in the headers. We have a podcast too. There's 2 sets. There's playlists that you can look at, which is like if I only want to look at anesthesia stuff, or if I only want to look at guideline stuff, or just cardiovascular, whatever. That kind of stuff is super helpful. The shorts are great, short little videos if you want to practice some practice questions, or if you want to look for the process of elimination and how to do those. A lot of those are in some of these videos, and they're short little lessons. Super cool. What's the differences between unspecified and specified? What's the difference between the brackets? All kinds of cool stuff in the shorts. Videos, you can look at the most latest, the most popular, or the oldest videos. You can sort them however you want to sort them. It's kind of cool. The home page will show you when the next live is going to be. It will be Thursday. Tomorrow's I have to reschedule for Saturday. Unless we do one at like noon tomorrow. I may have to just switch my lives to like noon every day instead of doing them in the afternoons. I don't know how popular that would be if anybody wants to get on at noon every day and just do the live lessons then, but it seems like we're getting too popular in the afternoons and it's hard to keep up. And then when you guys fall back or something, when y'all's time changes, it's going to be crazy. So I don't know. Maybe I should just do them at lunchtime every day. But all the replays are right there. Just click on the live button and that's where these are at. Super helpful. Yep. And if y'all enjoyed the Pocket Prep questions, don't forget the little linky is right there to get onto Pocket Prep. Those are always super fun to do. Is that where we were at? Yeah, we were here doing some Pocket Prep questions. Super fun. Love it. They give you the rationale and tell you where the answers are. That kind of stuff. If you don't know where the answers are, it'll teach you. If you go look on that page, you'll be able to find where the answers are. And then learn how to use your book, which is super helpful. Whether you have the ICD-10, the HIPICS, or the CPT book. Love how they show you the answers, where the page numbers where the answers are. Super cool. Alright, back to this one. Did you guys find an answer for this one? Oh, you paid for a class before you found me. Aw. Hey, Janelle. You got this one? I like Pocket Prep too. Yeah. I wish it had more E&M questions or more CPT questions. It's got way too many HIPICS questions, but I love it. I love it. It's 750 questions. You can't be picky. I mean, I could never have enough E&M questions. I have a ton on my page. I've got like 200 available on my website if you ever wanted to practice those. This one is C. There's your rationale for that one. Thanks, oh hey. Where are you typing from? What city are you in? Just curious if you're still on. You got that one correct. Yay, good job. Good job. It's hard when it's not just the one code, you know, we're not seeing all of the codes for that particular example is what I mean. You're having to only pick out just the first one. I don't know what happened to the YouTube video. Let's see. There we go. Still got 36 of you guys on, and we got 17 likes. Hopefully the internet is still working really well for you guys. All right, let's do another one. I got more cases coming up. Does the first listed code require a modifier for this particular example? Would we need a 51, a 78, or a 58 for that prior exam question answer? Do you need to look at it again to see? Or can you do it off of memory? Most of the time for AAPC practice exam questions and real exam questions, the answer will be no, you don't need a modifier. A lot of times they're pushing you to try to do a modifier, but in legs and arms, sometimes you need a modifier, but this particular one, you didn't need one. What is the E&M code for this one? We probably won't have MDM or time for this one, and it's going to be 3 pages. It looks like it's all established. Probably don't need that new patient code, so how would you code this particular one? You got to take your problem list, your data that you did, and your risk. Combine them all and give me a level visit. What would you do for this patient? 99212, 213, 214. Sorry, a year ago. That makes her an established patient. She has degenerative changes. Right knee pain secondary to primary osteoarthritis. Tylenol for pain. Still moderate because you gave her a medicine, even if it's over the counter for that. But her problem list and the data with the one x-ray looked at will still get you a C. Very good. Good job. Which is our low. Another one of these crazy ones, cases. This one we got all of the available answers. Would we be 3 CPT codes or would we be 4? Are we a 2829, 2, 9, or 5 as our very first code, our most difficult procedure that we did do? Would we be a 6 and then 8-5 at the end? we've got two that are a 99. This one is going to be 7 pages of cases. Before I worry about the 7 pages, definitely need to know my differences between those codes. So my 282 is what? What is going on with the 282 9-2 area? These codes will be on your exam, more than likely. I've got them pink highlighted. (9-2) is a bunionectomy. 9-5 is also. And so is our 9-9. 9-2 is the mama code. She's included in what 9-6 is doing, and 9-5, and what 9-9 is doing. 9-9 is a double bone removal, right? 9-5 is the proximal metatarsal was removed. Did we have an additional bone removal? What did we do? There's a bone removal. Did you remove one bone or 2 bones? If you only removed 1 bone, then you're a 9-5, right? If you remove 2 bones, you're a 9-9. If you didn't remove any bones, then you're a 9-2. Did you already have your one-word differences written down beside all of these codes so you don't have to figure it out later? Let's see, proximal with proximal osteoectomy. There is a sesamoidectomy in mom, so be careful because that's still a removal. So technically, if you count your 92, right, it does have 1 removal. Your 95 technically has 2 removals, and your 99 has 3 removals. So kind of think about it that way, because you got to consider what mom's got in it. Let me know if you need to see other pages. That's where they remove some of that. Proximal ostomy on the intermetatarsals. wires and screws. I messed up my PIP joint one time, falling at Disneyland. I have prescription glasses for driving, but not for like walking around and reading. I don't need them for that, but I need them for driving, just seeing signs far, far away. But the only pair of sunglasses I have are driving sunglasses. So I was trying to wear prescription glasses while I was walking that brought stuff closer to me than it was. And yeah, you shouldn't do that. I missed a step that wasn't where I thought it was because I was wearing prescription glasses that were only meant for driving, not for walking. Some of you guys have been with me long enough to remember that. My fingers all bandaged up trying to show you codes in the CPT book, and I had to go to physical therapy to get to moving them again because they froze and wouldn't move anymore because I kept them splinted too long. What do you guys think the answer is? Yay, good job. Having those one-word differences and remembering what mom's got in them, super helpful. Indeed, A is the answer. Good job. That one was difficult. What about this one? This one's going to be 4 pages. What's your differences between C and D and then A and B? You've got 2 of them under the 2, 3, 4 area, 2 of them under the 2, 3, 6 area. Knowing that difference in those headers will make this one a lot easier. This one's going to be 4 pages. I know you haven't seen these yet, have you, Janelle? We do have an implant placed. That sometimes can help out a whole bunch. Knowing whether you have plates and screws or wires and screws is a big difference in a lot of the musculoskeletal stuff. Then also knowing if you have an implanted or not. What do you guys think is the answer for this one? If we did a implant into this humeral head. Hey Raina, good to see you. Indeed. Perfect. This one is A. And do we need any modifier on the first code for this particular example? Would we need LT, RT, 50, or none? 2, 3, 6, 16. What did we work on? We were doing the arthroplexy. What do you guys think? Do we need a modifier? Good job. Yes, we do need that left one on that one. Perfect. All right, E and M one. Do you already know your headers for your E and M codes by sight? Have you memorized these? This is ER. This is a hospital consult. This is an admit hospital. And this is a observation that has an admit and a discharge all in the same day. If you don't know those headers without looking in your CPT book, be sure to get to know those. At least these codes. Super helpful to know that before on the exam. What are they asking us to code for? Neurology was called for a consult to see if we need to do an admit. What did the ER doctor do? Y'all saw this one on the workshop that we did on Sunday. Was the patient discharged yet? The patient is waiting to see if they are being admitted, correct? They're waiting to see neurology, whatever. So they have not been discharged, so you know it cannot be D. What did the ER doctor do? Place the patient into observation status. So the patient is no longer in the ER if they're placed into observation. So you cannot bill for ER. We're not billing for the neurologist who's coming to see the patient. They asked us to bill for the ER physician. The one on the workshop was just a little bit different, worded a little bit differently, but same premise. It said up here that the ER doctor admitted the patient to observation instead of placed. This one today says placed. Same thing. We can only bill admit hospital code for this patient all day long. If you don't see that the patient went home, was told to follow up with their PCP, you cannot bill observation. You also cannot bill observation if they're a Medicare patient. Medicare patient doesn't pay for consultations or observation with these codes anyway. They didn't ask us to bill for neurology. They asked us to bill for emergency room physician, and the ER doctor changed the patient's status from the ER to observation. Observation is an admit code. Very tricky one. This example will be on the exam. It might be written differently, but it's going to be there. Everybody knows what to do with this one. 7.1 and 7.5 are codes that are for older babies. They can't be utilized for babies, right? The only codes that are available for NICU babies, which are less than 30 days old, is only A and B. And since the baby is in NICU, NICU is a global code. We will never code anything with it. It's all in one code. So you know always your answer is A for this one. If this had been an adult you do get to bill for this kind of stuff if it was an adult, but babies, you do not. Anyway, A is your answer for this one, always. What are we reporting for this patient? My oldest, the IT director, is in Oregon visiting his best friend from junior high. My fourth son, Mr. Gabriel, he just sent me a video of them riding skateboards with his two dogs. Aw, they're so cute. There's Gabe. I can't believe they're in their 30s already. My oldest child. Gosh. Gabe is about 6 months older than John, so it's too fun. Oregon's really beautiful. It's about 30 degrees there in the middle of the night. It's super cold. Do I see any correct answers for this one at all? So we've got a comprehensive exam in the nursing facility, and we have a patient who was admitted to the hospital with moderate complexity. I've seen this one where the answer is either C or D. Older guidelines prior to 2023 would have had A only as the answer, that we would not bill for both facilities. But if they did perform the history and examination, we can bill D. As of current guidelines, and we are able to bill both services. So if they made a decision at the nursing facility to admit the patient, and that was their decision, and then they wrote orders to admit the patient, you can see why the answer would only be C, because you didn't make a decision at the nursing facility and leave orders for the patient or the nursing staff to continue taking care of that patient at the nursing facility. The history and the examination all ended up being an admit to the hospital. So in this particular question and its rationale, they only wanted the admit code. They didn't want the nursing facility code. And I can understand that particular part, but current guidelines do clarify that you can bill for both services, but the physician technically would have had to have left some orders for the staff to handle and to take care of the patient if they're going to bill for a nursing facility call, right? All right. This one. If we've got our 417, you know you're probably just looking for time for this patient. Did we spend enough time with the patient? Are they new or established? That's the first thing we got to worry about. And then time is different based off that. It is C. Remember, you've got extended time if they are a new patient. So 205, 99205, what's the time on that one? 99205. What is our extended time? It has to be for a 205, 75 minutes or more before you can add the 99417. If you looked in your CPT book, there's a parenthetical underneath 99205 that says you have to meet 75 minutes or more. Also, if you look on page 33 of your CPT book, there's an actual chart for prolonged services. When can you bill prolonged services for 99205 on page 33? It says it's 75 minutes, and then if you're going to times 2 it, you have to have 90 minutes down. Be careful. Just because it seems like it's a long time doesn't mean it's a new patient a long time. The times are really hyper out there when it's a new patient. When it's established, yeah, that would have been enough for this one, but not when it's a new patient. You got to be really way on out there with some time. Take the time to go look in your CPT books. Don't forget to look at those parentheticals. My brain is not functioning either. I don't know if you could tell, Janelle. You know, those workshops on Sundays really drain your brain, and I've had a good amount of sleep between now and then, but now I've had too much sleep, so my brain isn't working either. So I feel you. It's just we work too hard on Sunday. And, you know, sometimes you just got to walk away for a couple of days and then come back and be refreshed. No live tomorrow, but we'll be back on Thursday, and then we'll do one on Saturday. Yep, got to be 75 minutes. What about this one? Is our patient a subsequent hospital visit, or are they a critical care patient? Make sure I got the font where you guys can actually read it. At least 20. Those workshops, I know it's only 3 hours. Just imagine the certification exam is something you have to recover from when you do take those. They're very hard on your brain. I had the opposite sleep, not sleeping enough. Oh, I have a hard time going to sleep, so I'll lay there till like 3 in the morning and then sleep till 6:45. I got to get the kids up, start taking them to school. One's got to be at the bus at 7 a.m. The other one has to be at school at 8 a.m. and there's no bus for his school. And then I finally get home and get started on some work after that point. Remember, if they say anything close to 30 minutes critical care, don't just bill that just because it's there. There's a reason why they do 30 minutes. Be very, very careful. If you're going to bill something, you got to take the time off for doing it, right? So if you did intubation or trachs or whatever, you got to take 5 minutes off. And if you don't have 30 minutes of critical care time, then you know you're going to end up billing just a subsequent hospital visit. Another one from our workshop from Sunday was an example like this one. If they tell you critical care is 30 minutes, then they're just seeing if you understand that you got to take 5 minutes off for doing that procedure. So C is your answer for that one, because you did not meet the requirements needed for billing critical care. You got to be doing CPR and recession for a whole 30 minutes. And anything that you're going to bill CPT code wise with it, you have to take that time off of it. You can't double bill. That's fraud. So we do get to bill for our 31500. So we have to take 5 minutes off of critical care. Super important part that they will definitely ask you during your certification exam. Are you a 7.6 or a 7.5? What's your differences between those two CPT codes? That'll get you down to a 50-50 shot. Then are you a T82.3 or a T82.8? I hope so too, McNair. I hope so too. Write down anything that you can't. Remember into your CPT or ICD-10 manuals. It's super helpful. We're doing an open blood clot removal of iliofemoral or artery bypass with a revision of a graft. Whole lot in a little bitty sentence. We're definitely going to be an A or a B. Oh, I gotta go get Travi. There's an alarm. 358. $75 and $76. 76 is with the revision, and you saw we did the revision, right? So you know you're 76. Marking those differences down first is super helpful. 76 is everything that 75 is, except for it has the added on revision, right? It's also other than a hemodialysis graft or fistula. So not, other than means not a hemodialysis graft or fistula. Always put a line through those and get rid of it. That way, you know, I don't have that. A is your answer for this one. No, no, just make sure the questions and the answer is correct. That's all I want, Twink. Alright, what have we got here? We got move that down. I don't think that goes with that one. We've got either a 20 or a 22. What's our differences? 320. 37. $37, $220. Revascularization, or a 22. That's an add-on code. 37222 is an add-on code. So would we add radiology to this? Does it have angioplasty? Does it have radiology already included or not? That's the only question with this one. They want to know if you know what's all inside 37220. What'd you say? I was close on that one, but I got it wrong. Aw. No worries, no worries. Y'all get them wrong with it. Thanks, Jen. See you later in the week. Awesome, Katie. See you Thursday. Hopefully I'll be regenerated by then. Oof. What do you guys think on this one? You know it's not C or D, right? That's an add-on code. So it's got to be A or B. Do we need radiology? 75710. What is 75710? I know we did it, whatever it is. Just need to know if it's included in our CPT codes. Is an angiography included in our 37220? The way they did this one. The follow-up angiography was performed. They also did an angiography catheter with the angioplasty, and they did a diagnostic angiography, and then they did a follow-up angiography to make sure it had good flow afterwards. Do we get to bill for that, or is it already included in our code? What do you guys think? Yeah, that's what I've trained y'all to think, but in this particular example, because we did the diagnostic and we did a follow-up that already, so the diagnostic we get to, that's included, but the follow-up, when we already have a diagnosis, we figured out what was wrong with this patient, and we did another one after we had a diagnosis to make sure there was good flow. Yeah, we get to bill A on this one. It's just one of those tricky ones I showed you guys in one of my duct classes, of some of the areas that sometimes you get wrong on the exam. It's really tricky. It's the fact that they did the follow-up angio. So make notes near your CPT code here that says, okay to add this if you do a follow-up angio. That'll help you if you happen to get this kind of question during the exam. Me too, Janelle. I'm with you, dear. Don't worry. I love you guys. I will see you guys on Thursday. Don't freak out. These questions that I gave you guys tonight are the absolute worst of the worst classes. If you could see the name of this worksheet is Duct Class from 11/9/2023. So these questions were particularly very, very difficult, and they're usually ones that I don't show you guys in my lives because they are ones that are extremely difficult, and they're the ones that you'll just usually get wrong if you ever have to face these. These are the worst of the worst questions. It's not you. It's the way they're written, and don't feel too bad. It's just I did not have time to prep you guys any questions today. My brain is not working, so I had to pull up an old one, and I thought we'd do one that was going to be challenging, so don't freak out. These are really rough questions. These are stuff that would not be combined all together on a CPC exam, but one of these questions might be, you know. They do throw in a couple of tricky ones. I always say there's at least 15 that are on the exam that you're going to get wrong no matter what. You start off with your exam score is going to be 85. No one ever gets above that, right? So you're working from that level down that you want to make sure you capture any easier ones to miss. These were very difficult, so don't freak out. They are good to watch and play with. And if you want to see more of these more difficult questions by chance, if you ever do, let me show you. Where are we at? Not that one. I think it's this one. No, not that one either. This one. If you do want to see those questions that are more difficult, you can go to, of course, I can't figure out how to get there unless I go here first. So I'm so trained at my website. We're going to go to the YouTube channel, of course, and you're going to switch it over to playlist, and then you're going to find the one that's got the little ducks right there, and click on the full list right there, full list. And this is super helpful. When you click on the full list down there, you'll get a list of all the classes from my duck classes. And what did I tell you guys? It was duck class from 11, somewhere around there. So it's probably from this class right there. But if you wanted to watch any of these duck classes, just know when you go in there, these are the questions that are very difficult, but it's great. It's usually 2 to 3 hours of very tricky questions that are just designed for you to miss. And they're tiny little nuances that if you knew to look for in this question, you could get it right. But you wouldn't know that you needed to look for a subsequent angiography, right? That they did an extra additional one. So, super cool. That's where those are located if you ever wanted to watch those again. But they are difficult. But just, you know, go put the examples in the book. Once you figure out what the answer is, put the answers next to the codes that they are affected so that you've got the notes down for the next time you see a question like that. Love you guys. I will see you guys on Thursday, same time, and the links will be up there on the YouTube channel. I'm going to change them now so that you guys know. Not one tomorrow, but one on Thursday, and then I'm going to switch tomorrow's to Saturday so that we get all 3 of them done this week. So I'll see you guys later. I hope this was helpful.